Gardner and Eileen O'Reilly for moderating.
Next, we are going to turn to Stanford Children's Health's Dr. Roberto Gugig to discuss applications of ERCP and pancreatitis.
So thank you for the NPF for having me and for this nice introduction. So I am in charge of presenting to you the role of ERCP in pancreatic disease, but I noticed that you guys only gave me 15 minutes. So we're really going to talk about ERCP and its role in pancreatitis, and that's even a tall order. I want to accomplish today. First, I want to talk about some basic endoscopy rules that I learned when I was training, and it was eat when you can, sleep when you can, which I think still stand. But I did learn don't mess with the pancreas, and please don't cause a perforation. And as you'll see, we are messing with the pancreas and not the subject of this talk, but we do make controlled perforations now in patients to treat pancreatic problems and complications. So what I want to do is talk a little bit about backgrounds and really try to ask the question that I ask myself is, why do we have so many unanswered questions after having ERCP for more than 50 years? And then I'll focus on the clinical use in pancreatitis, mainly talking about stones, leaks, disruptions, and strictures, and I'll give you a small summary. And as you can see, pancreatitis incidence is increasing, and this is across all age groups, and I truly have not seen as many gallstone pancreatitis on the pediatric population like have in the past 5 to 10 years. And it's really no small task, because it's said that we spend about $30,000 per person in the United States. Mortality has been better, it's about 1%. But still, when patients come in multi-organ failure, pancreatic necrosis, the mortality can be as high as 30–40% still. And I'm stealing this from Tim Gardner, and really the importance of indication. The fact that we can do something does not mean that we have to or should do it. And I think, like he said, I don't know if he invented this or took it from somebody else, but you learn how to do the procedure in training. In the first few years of life, you learn when to do the procedure, and then thereafter you're learning when to not to do the procedure. So the first ERCP was described and done by William McCune in 1968. He was a surgeon. He spent 4 hours cannulating the ducts, and he said it was so dangerous and so complicated that really abandoned the procedure. By 72, Peter Cutton, who actually coined the phrase ERCP, was publishing the first of about 62 patients, which he did ERCP on. You can see what kind of papers you could publish at the Lancet at that time. Here we have cannulation of papilla bladder using a fiber duodenoscope. So I doubt that we could publish something like that in the Lancet nowadays. Therapeutic ERCP was born in sphincterotomy in 1973. Both groups from Germany and from Japan described the technique. Couple of anecdotes. The group in Germany, nobody really knows which of the two did the sphincterotomy, as they did at closed doors. And then Dr. Kawai, who's credited from Japan, actually never did any ERCP. It was Dr. Nakajima who's on the paper, but because of how things work in Japan, he was always first author and I guess took all the credit. So we've gone through a very long transition with the ERCP, going from diagnostic to therapeutic, then working on definition, cost-benefit ratio, quality, and it wasn't until 2000s that we started doing randomized controlled trials. So there's partly the explanation of why so many things we do not know about. And really, if you look at the trajectory, we started with observational case reports in the 70s, and it wasn't until the 2000s where we really did meta-analysis and systematic reviews, and compare that to medicine and gastroenterology, and you can see that we've really come a long way until we actually have some usable data to provide recommendations. Not surprisingly, the majority of innovation during the procedure happened at the beginning, and then there has been some innovation, but I would say slower since then. And it's no secret that we're using this as a therapeutic technique, and that's because we have really good diagnostic modalities such as MRCP here in the US. And so we rarely use it as a diagnostic modality. We are doing about 450 to 500,000 ERCPs in adults. And on the pediatric side, and this is for my group, it's been fairly steady, even though I feel like I'm doing more ERCPs than ever in children, but it's been about 11 to 1,200 ERCPs per year. And this is one of the problems, you know, this is from the NIH trying to provide some evidence-based, and they looked at 22 years of ERCP, almost 6,000 citations. They selected only 14 selected papers for review, so 149 articles in 20 years that they thought was suitable for inclusion to provide actual recommendations. So this is one of the problems that we've had for many years, to try to provide real recommendations. And this is just to illustrate one question that we've had for a long time, which is, do you do an early ERCP with gallstone pancreatitis? And you can see a whole slew of papers, some of them contradictory, to try to answer that question. It wasn't really until 2020 with the Dutch pancreatitis group and the study in the Lancet that we really answered that question. And really, unless you have cholangitis, it really makes no difference doing a very early ERCP or waiting a little bit. And why is that? Well, we really defer in the assessment of severity of pancreatitis, the timing of the ERCP, the exclusion criteria, and the endoscopy expertise, among the others. So even answering a simple question, as you can see, takes a long time. So let's talk about some specific conditions, such as leak and disruptions. I'll start. So this is a child, 17-year-old, admitted 3 times for recurrent pancreatitis with persistent right upper quadrant pain, no history of trauma, some mildly elevated amylase and lipase. On initial outside ultrasound in the ED, he had some fluid in the left upper quadrant. The MRCP, you can see, shows a leakage point towards the tail of the pancreas. So leaks can happen with acute and chronic pancreatitis. They can present in a variety of ways, such as pseudocysts, ascites, pleural effusions, disconnected duct syndrome, and internal and external pancreatic fistulas, which sometimes are quite difficult to diagnose. The majority of the diagnoses you can make with high quality cross-sectional imaging, but sometimes we have to use ERCP to actually make the diagnosis. I will repeat myself many times saying that these patients are complex and should be really managed not by only an advanced endoscopist, but we should talk to the IR, the surgeons, the pain team, in addition to all the other people that are taking care of this patient on the floor and as an outpatient. So do we intervene when we find a leak? And if so, when do we intervene? And usually when the patient's symptomatic, such as having recurrent pancreatitis, pain that we attribute to this, or when this leak is feeding a fluid collection, such as is in this example, a very large fluid collection compressing the stomach that has been getting larger on this patient, then we really want to try and diagnose and fix the leak. And these are 2 examples of patients that have leaks in the pancreatic duct at different areas. And so how do we fix the leaks? Well, we really fix them by doing an ERCP to bridge the leak if we can. And here we had to put 2 stents on this patient. And on the right side of the screen, you're seeing an EUS with aspiration placement of a stent to deal with a very large fluid collection. And really by doing these 2 things, we can tackle these type of patients. And so there's a multitude of stents, and this is part of the problem to compare studies because they differ in diameter, material stiffness, length, cost, whether the pigtail is straight, and with or without phalanges. And there's really no standard of care when it comes to putting stents, but there's some common threads, I would say, that most people follow. So ideally, when you have a leak, you want to put a pancreatic stent across that leak and really bridge it completely if you can. If it cannot be assessed because the pancreatic duct is completely disrupted, then you want to place it as close to the site of the leak as you can. You usually use smaller caliber stents, 3 or 4 French without phalanges when you have a low-grade leak, such as a sideband leak and no evidence of main pancreatic duct leakage. But you do want proximal phalanges because you want to keep the pancreatic duct stent in place for a longer time when you have a high-grade leak in the main pancreatic duct. And these are not permanent stents, obviously, but we keep them anywhere from 2, 6, up to 8 weeks at a time. And where does stenting come from? Well, we have some evidence from stenting in post-op patients, in post-ERCP pancreatitis, and in trauma patients. So we really extrapolate what we've learned from this in doing stenting when we have these leaks and disruptions with pancreatitis. And just a word of caution, and if you are doing ERCPs for enough time, really the procedure and the patients should keep you humble. And this is a patient of ours that had a pancreatic leak that we put a stent. The patient did really well, was out of the hospital, and I was ready to collect my medal and my trophy, only to find out that 18 months later, the patient had a stricture that I had to deal with afterwards. So, don't count your victories too early, as I would say. So let's talk about stones. This is another patient of ours, 15-year-old with chronic pancreatitis, PRSS1 mutation, followed by the pain team. He had like 5 admissions over 11 months, mainly for pain. And because of that, he underwent a celiac plexus block with improvement over 7 months. However, his pain then increased over the past 6 weeks and when hospitalized, was found to have, as you see here in the bottom, a pancreatic duct stone that was quite large. And again, if you see a stone, do you have to take it out? I think if the patient's symptomatic and we think the patient's symptomatic due to the stone, and that's sometimes hard to determine, then we say, yes, this would benefit the patient. Remember that not all calcifications that you see are inside of the ducts, and we frequently see patients like the CT that we have on the upper right-hand side with a multitude of calcifications. And really you look for, is there any evidence of increased intraductal pressure? Is the duct dilated after the stone? Is there any stricture before that stone? Do we really think that the intervention will help the patient? And I know these are difficult questions to answer. And just to throw this out there, the pancreatic duct stones are really more technically difficult to tackle than biliary stones. So just keep that in mind. We have a variety of accessories to use. We use balloons and baskets and sometimes intraductal lithotripsy using a cholangioscope such as spyglass. And we really sometimes need the use of extracorporeal lithotripsy. This is done mostly in nephrology or urology centers now, not in GI centers. And we are using this, I would say, less and less. I don't remember the last time that I sent a patient to have extracorporeal. What we're using the majority of the time is intraductal lithotripsy. And this is kind of an algorithm of tackling the radiopaque and radiolucent stones. If we have to use extracorporeal, sometimes we use it when the stones are very large, more than 5 or 6 millimeters, and we don't think that it's amenable to endotherapy, and where pain is predominant symptom. Again, that most of these patients have pain, but where we think that actually removing the stone will improve the patient's pain. Remember that we don't want to use extra shockwave lithotripsy in patients with extensive calculi of the head, the tail, when the calculi are isolated to the tail of the pancreas, because we can injure the spleen, and where you have strictures, head mass, pancreatic ascites, or pseudocysts. These are not the ideal patients. So in the majority of patients, we actually do use intraductal lithotripsy, and I'll show you one such case here on the left upper side of my slide with the video. And you can see coming into focus, hopefully, the duct and the stone. I mean, I think the images now with these high definition cholangioscopes are really good. And for those of us who are older with gray hair, this is like playing asteroids. So you essentially are fragmenting these stones using the lithotripter in the duct. And so these flashes that you see there is us actually applying the electrohydraulic lithotripsy, which is what I use the most. There are laser systems, but at least in California, it's kind of a pain to get all the permits to use them. So we use essentially electrohydraulic lithotripsy the majority of the times, and it works fairly well. So there are some data that we need to pay attention to, and this is a study comparing surgical drainage versus pancreatic drainage. Again, these are 39 patients. Don't think this is like a large, but it's a well-done study, and in these instances, we have multitude of stones. I think if you compare surgery and endoscopy, it really favors surgery. So, the fact again that you can do a procedure doesn't mean that you have to do it. It will benefit the patient. Let's talk about strictures. There's a 14-year-old patient with a recurrent episode of pancreatitis brought to the ED after developing jaundice. And a little bit different if this patient was 44 or 64, because the malignancy may be higher up on the differential. The initial abdominal ultrasound showed an enlarged head of the pancreas, dilated common bile duct, and pancreatic duct. So we did an EUS, obtained biopsies that showed features consistent with autoimmune pancreatitis. So let's talk about strictures. It's a common problem. You can see them with benign or malignant etiologies. In benign etiologies, which is what I see the most, is usually chronic pancreatitis, recurrent pancreatitis, trauma, surgical complications. Malignancies I sometimes see, although I don't see in pediatrics adenocarcinoma. I've seen like 1 or 2 in my life, but I do see pancreatoblastomas, pseudopapillary tumors, neuroendocrine tumors, lymphoma. Those I see, but not adenocarcinomas. But anyway, the other thing I want to mention is that you really want to try to determine what the etiology of the stricture is, because the treatment may be a little different. And again, if you have an asymptomatic pancreatic stricture, you might want to leave it alone and not intervene. And we do have data for both plastic stents and fully expandable metal stents, usually covered stents. I rarely use metal stents in pediatrics and in pancreatic strictures. And you can see on the plastic stents that most studies show, and this is what our experience shows as well, a very good immediate success in the 80 to 100%, but long-term success is less favorable, I would say. So just keep that in mind. And you know, with any metal stents, you can have a variety of complications. So just to keep that in mind. And again, I don't use a lot of metal stents in the pancreatic duct. So strictures, it's important to understand the etiology, as I said. So if it's autoimmune, like my example, then you want to do steroids or other immune-specific drugs. If it's inflammatory, you do want to try stenting. And if it's malignant, you really want to treat the tumor. And really, when you do approach this via ERCP, you want to do a sphincterotomy, you dilate the stricture, although sometimes you don't need to dilate, and you place a pancreatic stent across this stricture. And you can see that you get very good immediate relief, but the sustained relief is probably in the 50–60% range for the majority of the time. So you just have to be careful and set expectations for the patient and for, in my case, for the family. You want to try to mark the stents if you're deploying pigtail stents, because you don't want to have an introductory deployment of the stent. So you want to know when to kind of deploy the proximal side of the stent. And these stents are not permanent, and so we keep them usually around 6 to 8 weeks the majority of the time. And so like any stent, you can have complications such as migration, obstruction, a secondary stricture, like I showed you in my example. And you can actually have ductal injuries and leaks from the stents. And so if you work in a large center, you'll see referrals of patients that have been injured by stents that we are now trying to deal with. So even though it's plastic stents, they can still cause damage to the pancreatic duct. And I'll leave you with a last example of something that is quite satisfying when you can find it. This is a 3.5-year-old patient with intermittent abdominal pain, 2 documented episodes of pancreatitis with some elevated AST, LT, alk phos, GGT, but normal bilirubin. The ultrasound and the MRCP showed kind of enlarged gallbladder, dilated ducts, and maybe a stricture in the distal common bile duct. And so this was a type 3 colorectal cyst, which you can actually address via ERCP, and it's quite satisfying to open these up and do a papillotomy. You can see an ultrasound before and after with decompression of the ductal system. So in summary, again, the importance of the indication, this was hammered to me when I was learning ERCP on the adult side. Again, the fact that you can do something does not mean that you should. There's still a lot that we don't know, as you can see, and some of the reasons are because we really have not had very good comprehensive systematic review type data to provide adequate recommendations. The majority of recommendations are from quote unquote expert opinions. And we really want to, I think all of us do the right thing, but I think this is an encouragement to some of the fellows who may be interested in pancreatology and advanced endoscopy, that there's a lot to find out and discover and share with the world. You want to choose your accessory wisely. And again, most of these patients are quite complex and benefit from a multidisciplinary team that includes not only the advanced endoscopies, but surgery, pain team, IR, etc. And then the last thing, this is where I work. I'll leave you with my email in case somebody wants to reach out, and with a quote that the greatest obstacle to discovery is not ignorance, but the illusion of knowledge. So sometimes we don't know, or we think we know what we don't know. So thank you very much again. And hopefully next time we can meet in person. Thank you.
Okay, thank you, Dr. Gugig. So our last speaker is Dr. Aliye from the University of Iowa Stead Family Children's Hospital, and she's going to talk to us about pediatric pancreatitis.
Hello, everyone. I'm Aliye. I'm from University of Iowa, Pediatric Gastroenterology Division. And it is my pleasure today to talk about pediatric pancreatitis, current state and path forward. And I would like to thank NPF for inviting me to give this talk today. I have no disclosures. And this is the outline of my talk. I will talk about the epidemiology, presentation, and etiologies of pancreatitis across the pediatric age groups, and how pancreatitis is different in children versus the adults, and the risk factors that are associated with progression from acute to chronic pancreatitis in kids, and what challenges we have for pediatric pancreatitis, and how can we turn that into opportunities, and future opportunities and future directions, and where do we go from here? And as you may all know, that the pediatric pancreatitis has increased in incidence since early 1990s. That has been reported not only in the US, but in Europe and in Asia, with an incidence that approaches about 1 in 10,000. That was probably an increase in recognition of the cases because it seems to have stabilized for the last 10 or 15 years. And this is a study from a large insurance gathering of the data from Stanford, the first author being Zach Sellers. But has been shown that the incidence has stabilized in the pediatric patients and slightly decreased in the adults for both acute and chronic pancreatitis. It's more common in adults than in kids, with acute pancreatitis again being around 1 in 10,000 in kids, and chronic pancreatitis about 2 cases per 100,000 per year. And here I will give you a case presentation, and if a kid like this who is a teenager presents with an acute onset of abdominal pain and vomiting, no fever, normal vital signs, and exam showing tenderness on the epigastric area, I think most ERs will order an amylase and lipase study and will make the diagnosis of acute pancreatitis. It would be important to send labs looking for serum transaminases, GGT, and bilirubin. And for the first attack of acute pancreatitis, it is very important to do an ultrasound as well. As you see here, you can see the gallstones and a common bile duct obstructed with a stone here. You don't always see it that clearly. But this is a clinical diagnosis of an acute pancreatitis and a biliary pancreatitis. So this will respond, of course, to surgical treatment. So this is not that different between pediatrics and adults. And we have the definition of acute pancreatitis, and this was established by the INSPIRE group that I have been involved from the very beginning. And it is very similar to Atlanta criteria. And the diagnosis is very much clinical. So we require 2 out of the 3 criteria that involves abdominal pain, amylase and lipase elevations, and imaging findings. And the etiologies in children and adults are a little bit different. With adults, most common findings, etiologies would be gallstones and alcohol, and then some idiopathic etiologies versus in kids. There's a variety of etiologies, most common being idiopathic. Then we have viral infections, medication usage, anatomical problems, trauma, and systemic illness. So it's and gallstones. So it's a variety of etiologies. When it comes to young kids, the presentation may be different, that requires quite a bit of suspicion, such as this kid, a 2-year-old presents with irritability, crying, vomiting, constipation, poor oral intake, a low-grade fever, and toddlers notoriously are very difficult to examine. And if an X-ray is taken, you can see a lot of stools, which, by the way, is not a great way to diagnose constipation, but a lot of times that's what happens in ER. So this could be seen as a kid, perhaps with viral infection, stomach flu, constipation. Unless somebody orders an amylase and lipase, acute pancreatitis may never be diagnosed, and sometimes those kids will be seen multiple times for acute pancreatitis. Even though they have recurrent acute pancreatitis, they will never get the diagnosis, so it requires really a diagnosis of suspicion. So there are variations within the pediatric age groups, such as older children can present with abdominal pain and vomiting, versus infants and toddlers. There could be a variety of presentation. They could be irritable, they could have fever, and vomiting and abdominal pain may be more in the background, and may even be abdominal distension. So I think those are the things to keep in mind as we look at different age groups in pediatrics. And the etiologies may also be different, like in kids less than 2 years of age, we see more inborn errors of metabolism, metabolic disorders, and trauma, versus in older kids, like older than 11 years of age. Think about more idiopathic etiologies, medication usage, viral infections, or systemic illness. So there is a spectrum in those patients. So a lot of times, kids presenting with acute pancreatitis, it will be only one attack. We will never see them again. So that's about 65 to 85% of the time. There's a range, but 15 to 35% will have recurrent attacks, and some will progress to chronic pancreatitis. So we have a definition of acute recurrent pancreatitis, something that we see commonly in pediatric age group. As INSPIRE, we have this definition. They should have at least 2 episodes of acute pancreatitis. And we put a time interval here. It should have at least 1 month interval in between the episodes. But if the patient is completely normal, like no pain, normal amylase and lipase, you don't have to have that month in between attacks. And some of them will progress, as we talked about, chronic pancreatitis, exocrine pancreatic insufficiency, and islet dysfunction and diabetes, because pancreas, as you probably know, has an exocrine component and an endocrine component. And our definition of chronic pancreatitis also reflects that. I mean, patients will have some imaging findings associated with chronic pancreatitis. Those are irreversible changes that I describe here. I'm not going to go into details due to the time, but you have those imaging findings with abdominal pain or with exocrine pancreatic insufficiency or some diabetes. But we also have found patients in the INSPIRE cohort without abdominal pain and having those advanced findings. That is a small portion, about 10% of the cohort, but those patients exist. So here, talking about the INSPIRE study that I've been involved in, and a lot of the data that I will present is from that study. It started really as a concept in 2009. It was funded in 2012 and continues to be funded. Now we have about 26 sites and about 800 patients. We're part of this large consortium along with the adult cohort called CPDPC Consortium, and it is a natural history study looking into pediatric pancreatitis over time. This is just the sites that are associated with INSPIRE 2 study. So our goal is to follow the patients over time, collect the clinical data, samples, biosamples, to really understand what happens to those kids over time, and the risk factors associated with progression and sequela, of course, the exocrine pancreatic insufficiency and diabetes, and understand if we can develop better diagnostic guidelines and treatments. There are a lot of lessons learned. I'm going to try to really, in a short amount of time, try to summarize, but what we have understood is most of them are related to the genetic risk factors. That is true for chronic pancreatitis than acute pancreatitis. And the second most common reason would be obstructive or anatomical factors. And again, the most common being pancreas divisum. We're still trying to understand the risk factors such as medications, their involvement, and then alcohol and smoking that are most commonly seen with adult pancreatitis is not important in the pediatric cohort. One genetic factor, the PRSS1 or cationic trypsinogen gene that we found is important in the rapid transition from acute recurrent to chronic pancreatitis and is associated with chronic pancreatitis. And then there's a percentage of the cohorts that manifest exocrine pancreatic insufficiency and islet dysfunction or diabetes, but those numbers, I think, will change as we understand the cohort better. It has a great impact, and we talked about it's not a very common disease, it's an orphan disease, but it has a great impact on children and the families. And one thing that just came out from our group is that the quality of life, the physical quality of life especially was quite low in those kids, not so much the psychosocial well-being. And that low physical quality of life was significantly associated with pain and especially constant pain. So this is something that is important to follow up over time and see how that is impacted with interventions. Talking about the challenges, as I alluded earlier, the diagnosis of chronic pancreatitis is very much imaging dependent. And that's not only true for pediatrics, but also for adults. As you see here, ductal changes with ERCP and calcifications on the CT. So, and those are late changes. So by the time these are manifested, the disease is quite advanced. So can we diagnose the CP at an earlier stage with non-invasive biomarkers? Can we intervene? And that is the focus of the consortium that we are in. And another challenge is we depend on the radiology to make the diagnosis, but these radiologists that we work within the consortium, within the INSPIRE consortium, they look at the CT and MR findings, and there was not a strong agreement among radiologists about the findings of chronic pancreatitis. And this was published just recently. So this is something that we need to work on. So this is another challenge. So looking at the INSPIRE-2 within the consortium, so this is our cohort. We would like to follow those patients over time, and we would like to develop interventional studies to make sure that we can have an impact over time to the disease progression, make sure that we have biomarkers that we can develop, look at the outcomes, and have ancillary studies that understand diagnostics and therapeutics to improve the lives of the children with these diseases. So where can we possibly go from here? I mean, if we think about it, in 1990s, we were just understanding that the pediatric pancreatitis is actually an entity. And now we're coming up with diagnostics and prognostics. So where do we go from here in this short history of the pediatric pancreatitis? I think identifying the risk factors for severe acute pancreatitis, acute recurrent and chronic pancreatitis, and how can we determine prognosis going forward, and improving the lives of the children and the care, especially for children with severe acute pancreatitis. And can we define the role and the timing of endoscopic or surgical interventions is something else we can focus on. I think nutrition is important, and defining exocrine pancreatic insufficiency, diabetes, and bone health. Biomarker development and validation, especially for severe acute pancreatitis and progression to chronic pancreatitis, and how we can intervene. and developing standardized imaging criteria for pediatric pancreatitis, and pain, better descriptors of pain, and quality of life, and especially better therapeutics and treatments that target the root cause, especially important for pediatric pancreatitis that doesn't have environmental factors. I would like to thank the team, my co-PI, Dr. Lowe, my team at the University of Iowa, Gretchen Kress, Karen Scudero, my coordinators, and my pediatric endocrinologist, Dr. Katie Larson-Odi, CDMC team at MD Anderson, Inspire Group, PIs and coordinators, and our funding source, NIDDK and NCI. Thank you.
Thank you, Dr. Uch, for that wonderful presentation. As a reminder to the audience, be sure to place your questions in the Q&A, and we will be getting to those. Raise your digital hand to participate with video. We will not be pulling questions from the chat.
So we have a question from Dr. John Lee. That's for the whole panel. The boards often ask which genetic condition has the highest risk of pancreatic cancer, PRSS1 and STK11, and I still see many books and societies saying PRSS1 incorrectly, probably based on older data. What can we do to correct this? Anyone have any thoughts on? It's not really something anyone addressed. Oops, just a minute. Some of these look like they were for the other one. Okay, here's one for Dr. Lee. Here's one for Dr. Gugig. Do you recommend TPIT for the 15-year-old patient with chronic pancreatitis and PRSS1 mutations?
It depends. I mean, we've all seen patients with chronic pancreatitis that are actually doing okay, and then others are coming into hospital frequently with chronic pain or other problems. So I would say it depends. I've seen a wide variety of presentations, really, and depending on what complications they're having from the chronic pancreatitis.
Here's one for Dr. Lee. The issue of focally dilated pancreatic ducts in the absence of obvious cutoff sign or chronic pancreatitis is quite challenging. When do you go on to pancreatoscopy for those folks? I find a true fish mouth is rare, and most of these folks have indeterminate CEAs, like around 50.
So the question is about a mildly dilated pancreatic duct with no stricture.
Says that the issue of focally dilated ducts in the absence of an obvious cutoff sign or chronic pancreatitis is quite challenging. When do you go to pancreatoscopy?
Yeah, I agree. This is a tough conundrum, right? Which we face not infrequently, where we see this mildly dilated main pancreatic duct without all calcifications that would point us to chronic pancreatitis or something else that leads us to chronic pancreatitis. So we're kind of sitting there scratching our heads. And Darwin, you've been part of our pancreas conferences before, where we're like, okay, is this chronic pancreatitis? Is this main duct IPMN? Is this just the patient? Very, very tough situation. And I think it partly depends on how dilated the main pancreatic duct is, because if it's only like 4, 5, 6 even millimeters, depending on how old the patient is, I think it's reasonable to potentially just continue to follow these patients closely with a good quality MRI. Obviously, if it's much more dilated, you're more worried. And that's when you start thinking about, okay, should I do an EUS, stick a needle into the pancreatic duct and aspirate that, sending it off for CEA, glucose, perhaps DNA markers to see if that helps us to figure out if this is a main duct IPMN or not. Obviously, you don't need to send off an amylase situation because that will be high, as well as cytology. Pancreatoscopy, I think, is a last resort option, in my personal opinion. I think that if you're really not sure, you are worried for some reason, depending on how dilated the duct is, or maybe it's getting bigger, during follow-up, and EUS has not been helpful, then, perhaps you have a discussion with the patient, because of course they are at higher risk of getting acute pancreatitis from doing this. It's not a benign procedure. As you saw, we try to avoid doing diagnostic ERCPs nowadays, and it's mainly therapeutic. But I would have a conversation with the patient as well as your surgeon in a group setting and talk about, okay, does this make sense in this situation to do pancreatoscopy? And if you're lucky, you'll see the fish eggs, do some biopsies, and then you have your diagnosis. But honestly, in my practice, it's pretty darn rare, that we're resorting to that at this point in time.
Okay, here's a quick one for Dr. Uch. What are the recommendations for genetic testing in pediatric acute pancreatitis, a single idiopathic attack, or after 2 or more?
Thank you for the question. I recommend genetic testing after the second attack of acute pancreatitis, or if a patient have any signs of chronic pancreatitis. I mean, sometimes patients would present as their first presentation with chronic pancreatitis. I do not do genetic referral anymore because, they are really very good in like cystic fibrosis. At least in the pediatric population, for, single gene disorders, cystic fibrosis, and that sort of thing. But, for all those very complex genetic counseling, I think I educated myself to just sit down and really go over the genetic counseling, because I do the 13 gene panel, and there are several gene panels. And then I just sit down and go over each and every one of them. And obviously the one that's most impactful are the ones with the autosomal dominant mutations, such as PRSS1. But all the other ones have a meaning. I just, draw the pictures and with the duct and the acinar cells, and sometimes it just really goes over their head. But, I just, at every visit, I just go over and over and over again. Sorry, it's not a short answer. But yes, I do with the second attack or chronic pancreatitis. I do it myself, and I don't ask for genetic counseling. I used to do it when we had only like 2 or 3 genes, but now we have so many.
Just to follow up on that, and I don't want to belabor the point, but Dr. Uch, I was going to ask you, there's a big idiopathic etiology there, and that really warrants further discovery. And I know Inspire is going to answer a lot of these questions, so you're gonna open up the envelope one day. But that idiopathic group in the adult population, it's shrinking because of genetic testing. So this is yet to be discovered, right? That idiopathic group in pediatric pancreatitis, what is that group?
Well, it is shrinking, but that's a good
It is
question.
shrinking.
And a lot of them have never had any genetic testing, so that has to be done.
We're going to find out from Inspire.
All right. So here's another question for Dr. Lee. Can you comment more on the role of cyst fluid glucose versus CEA for diagnosing mucinous cysts?
Great question.
Yeah, so CEA, was the initial one, as I mentioned, by Bill Brugge's pioneering paper in Gastro. Not perfect marker though, sensitivity, specificity kind of in the 70–80% range. So tons of research. There's a meta-analysis that was done actually by one of our fellows at the Brigham, who demonstrated that cyst fluid glucose seems to be better than cyst fluid CEA alone at diagnosing mucinous cysts. So I think, there's been more and more literature coming out about the efficacy of cyst fluid glucose. And in my personal practice, I actually send both. And I will, use both. Obviously, if they're, going in the same direction, that's great. If not, I'll use, I'll see one versus the other, and then make a determination of whether or not I want to do any genetic testing after that. But cyst fluid glucose, simple, easy, cheap to do. So I would suggest doing that.
Dr. Gugig, tell us about pediatric ERCP training. A couple of years ago, there was a big discussion, a breakout session at the NPF Fellows Symposium. Tell us about pediatric ERCP training, the need for it, ease of getting it done, or difficulty in getting it done.
Well,
Oh, I'm sorry. I thought the question for me. Sorry.
okay.
No, it's for you.
You can talk if you want. I'm okay.
Let Roberto talk, please.
So I would say yes, it's needed because while most adult ERCPs are comfortable doing, a 15, 16, 17-year-old patient, I think the smaller patients, even very experienced people are intimidated by doing, a 3 or 4 or 5-year-old ERCP. So I think it's definitely needed. And then in many institutions, you have to transport the pediatric patient to the adult facility. That stresses everybody out, really. The training, obviously, it's not easy because I, like many others, have to train with adults because that's where the volume is. I mean, I do 150 to 200 ERCPs in pediatrics a year. While when I trained with the adults, I trained in a place that did 1,900 ERCPs per year. So you can see that, most ERCPs on the adult side are doing 400 plus ERCPs. And so that's not what you see on the pediatric side. So we have to train with the adults, or at least have some volume of the adults. And so that becomes very difficult because it's not only very competitive, as you probably know, but they expect us to do call on the adult side, and it's not easy for a pediatrician to take call on a 75-year-old patient with multiple medications on the adult side. So yes, I had to piecemeal my training, meaning I had to do ERCP in one place, EOS in another place, poem in another place. So I had to it took me a lot longer to get things done.
If I could just add one comment to that, because we've had experience at the Brigham in training, children's GI attending, Grover, Ahmed Grover, and he's an attending, and, he thankfully did not go through a competitive process like it sounds like you did, Roberto, because he's just right across the bridge from us. So we said, hey, yeah, we'll train you, but it's going to take, obviously, since he's working as a faculty already, had to kind of piecemeal it together with his current PD, attending responsibilities. And we were thankfully able to carve out time for him to do cases on his own with us. But it took longer, right? It took like almost 2 years for him to do that. And actually, he continues to work with us to keep up his volume because obviously we don't want to train you guys up and then, you do like 50 cases a year or something and lose all the skills. So
absolutely
tough, but doable if you kind of think creatively and work creatively with the folks around you.
In the places I have been, it's not really a competition thing, right? We're not competing for volume. Like you said, it's 150, 200. It's not really a volume thing. It's a matter of, can we get you skilled up to do this? That's the issue. Can we get you the numbers you need to get back to do it? And it's going to take a long time, to get that done. So yeah, that's great. So I have a question for Dr. Lee. It's a very practical question. How do you, if I'm going to start seeing patients with pancreatic cysts, how do I track these patients? At my clinic, if I start seeing a bunch of cyst patients every week, how do I keep track of all these patients?
Yeah, that's tough.
6 months, 1 year, 2 years.
Yep.
How do I keep track of all these people?
It's really tough. In the beginning, way back when, I used to keep a spreadsheet, which obviously is not practical. Now that you have electronic medical records, most of us do, you can leverage that. So, we have thankfully, we're blessed to have a medical informatics expert in our GI division, Lynn Chen, who's fantastic. And, using Epic, which is what we have, you're actually able to pull up all your pancreatic cyst patients. But honestly, what's even easier in a sense is that, all these patients I'm ordering MRIs on or CAT scans, if they can't have an MRI. And our radiology department is fantastic because they will track down these patients and schedule them. And if they cannot reach them, they will send me messages saying, we could not schedule this patient. So that's another kind of safety net. So I would leverage the electronic medical record system that I think most of us have now to keep track of these patients. Because you're right, rare but devastating if you lose track of somebody and they develop a cancer.
There is a question in the chat. I'm going to ask Roberto. It says, if a patient has a stricture as a result of hereditary pancreatitis and they do well with the indwelling stent in their PD and worsen every time you remove the PD stent, how long of a stenting / ERCP restenting can you keep doing at intervals of 8 weeks? Is it a year or two? Is a year too long? Longer than a year? What do you recommend?
Yeah, again, I go back to I can always do an ERCP and I can put stents. I think at some point we have to, if we're at this same stricture, same place, we're upsizing and we do not see a result or we see recurrence, then I think at some point it's time to involve your pediatric surgeons and say, well, we have to do something. Because, I'm sure that all of you guys have seen, I've seen patients that come to me that have had, 35, 40 ERCPs. I mean, at some point we need to say, stop the insanity and let's do something that's better for the patient, as opposed to saying, oh, no, I'm going to do the ERCP. That's going to be the best. That's going to solve all the problems, In
the adult world, we kind of give it about a year. And if after a year, you haven't made any progress despite, upsizing stent or putting multiple plastic stents in side by side, we don't really do fully covered metal stents, even though there's a little bit of literature because it's just a higher complication rate with that. But after about a year, no progress, then we're saying, okay, time to move on.
Yeah, I agree. I tell the parents that I'm going to keep stents between 8 and 12 months and then decide if this is working or not.
Okay, thank you all very much. We are now going to end this session, and there's a trivia question that's going to be coming up now. Thanks to our panelists. Thank you all for your great questions. Trivia question number 3, what percentage of the pancreatic mass comprises the islet cells? Do not answer in the chat, please. What percentage of the pancreatic mass comprises the islet cells? Do not answer in the chat.